Bismillahirrahmanirrahim. Our today topic of discussion is nutrition of the surgical patients. Bismillahirrahmanirrahim. Our today topic of discussion is the nutritional assessment of the patient, surgical patients. The patients which enter in surgical department, it is very important to have proper pre-operative evaluation of the patient. You should know whether the patient is malnourished, well nourished, or poorly nourished. So, what is the nutritional status? Nutritional status is a patient which should be assessed according to their height and weight, and that shows the post-operative morbidity and morbidity will be good or bad. It actually reduces perioperative morbidity and mortality. For example, if the patient is malnourished and you did surgery, there may be chances of very poor healing of the wound. There may be chances of very bad recovery of the patient. So, it is very important that you should assess the patient nutrition level before surgery, especially in elective patients where there is no need of urgency. You can easily do the delay the surgical procedure. So next question is, how will you evaluate or how will you assess the nutritional status of the patient? There are certain points. Number one is the history, then physical examination, then anthropometric measurements, then laboratory test, then immune functions. Like other diseases, history is very important. And what are the basic points of the history? First of all, check the change in dietary habits. Patient is taking a good oral diet. Check if the patient is having the weight loss. 5% weight loss in last month and 10% over 6 months is very significant. Then evaluate the body mass index, which most of us routinely doing. What is the body mass index? The formula for the body mass index is weight in kilograms and height in square meter. So normal body mass index is between 18.5 into 24.5. If the body mass index is less than 18.5, there is nutritional impairment of the patient. If the body mass is less than 15, there is severely malnourished patient. And if the patient is overweight, it will be between 25 to 29.9. So, by putting your height and weight, you can easily assess your body mass index. Rather, we all can do it easily at home. We can do for our family members also and check the nutritional status. Then get the proper history of anorexia, nausea, dysphagia, GERD, gastroesophageal reflux disease, then generalized muscle weakness. Then do the physical examination. Physical examination, check for the skin. Check skin, if the skin is loose, flabby, definitely there is loss of fat stores. Check peripheral edema. The most common cause of peripheral edema is hyponatremia. There are some other causes like kidney failure, liver failure. Then check muscle weakness, especially thenar and temporal muscles. Other changes like skin rash, pallor, glossitis, or hair changes, hepatomegaly, neuropathy, dementia. These all things should be assessed properly. So after taking good history and doing good physical examination, go for the anthropometric measurements. Anthropometric measurements are some sort of common physical measurements like tricep skin fold thickness, mid-arm circumference. So tricep skin fold thickness, how you can assess the tricep skin fold thickness? Just pick up the skin of the tricep muscles in the arm, take a vernier caliper, pick that, put that skin part between the prongs of the caliper and check the fold thickness. It reflects the fat stores. Then look for the mid-arm circumference, muscle circumference. It will give you the clue regarding the skeletal muscle mass. Then the fourth one is the laboratory test. Laboratory test, check the serum albumin, pre-albumin and transferrin level. The serum albumin level is less than 3 gram per deciliter in a normal hydrated patient. There are chances the patient is malnourished. And again the pre-albumin level, if the pre-albumin level is less, again the chances of malnourishment. Then go for the serum transferrin level assessment, less than 200 milligram per deciliter, again significant for the malnutrition. So after taking good history, physical examination, anthropometric measurements, laboratory evaluation. The fifth one is the immune status or immune function of the patient. As you have already heard that in the pathology, delayed type hypersensitivity, which is the most common type 4 hypersensitivity and mostly occur due to allergy to common skin antigens. So check the delayed type hypersensitivity level, check the lymphocyte count levels. 1500 to 1800 per cubic millimeter shows the mild depletion. 900 to 1500 cubic millimeter shows the moderate depletion, and less than 900 cubic millimeter equals severe depletion. So lymphocyte count level will give you some sort of clue regarding the immune function of the patient. So after knowing the nutrition or malnutrition, these 5 steps are used for the assessment of the malnutrition. Then is the caloric requirement of the patient. The rough formula or estimation of the caloric requirement is 20 to 30 kilocalories per kg per day, which is about 1300 to 1800 kilocalories per day. But in stressed patients, the requirement increases, which rises to 25 to 35 kilocalories per kg per day. So in this way you can easily calculate the daily caloric requirement of the patient. In this basic caloric requirement, you can add the daily losses like sweating, urination, stools and breathing. There are certain losses which can be added, but the proper basic requirement is 20 to 30 kilocalories per kg per day. So we have discussed what is nutrition and how assess the nutritional status of the patient by history, by physical examination, by anthropometric measurement, by laboratory test, by immune functions. Then we go through the caloric requirement of the patient. Then there are some other nutrients which are required, like glucose, fats, vitamins like vitamin B and C, which is very important, especially for wound healing of the patient, and especially if wound healing are affected by these vitamin deficiencies, the surgical patients are more prone to do this. Then is the minerals like sodium, potassium, phosphate, then trace elements, magnesium, zinc and the iron. Sorry. So next is, what are the indications of the nutritional requirement in malnourished patient? What are the indications of nutritional support or requirement in malnourished patient? So indications are, actually before starting the indication you should know what are different types of nutrition. One is the total parental nutrition, and second is the PPN, TPN and PPN. So TPN is total parental nutrition and PPN is peripheral parenteral nutrition. So difference is in TPN we use the central main vessels, and in peripheral parenteral nutrition we use the small vessels like cubital and the saphenous vein. So indications are prolonged hypermetabolic period. Even pre-operatively well-nourished patient who enter prolonged hypermetabolic period may require nutritional support. Without this support, definitely immune function will be compromised, wound healing will be compromised, and if both of these things are compromised and there is no a good protein bulk in the body, then of course the visceral protein reserves are used for these purposes and the body requirement. So prolonged hypermetabolic period. Second is the short bowel syndrome like mesenteric infarctions and proximal fistulas. In mesenteric infarction, for example, the infarction of the superior mesenteric artery, large length of the small bowel will be lost. In proximal fistulas, again, there are loss of fluids, electrolytes, and proteins, carbohydrate, fat reserves are lost. So short bowel syndrome. So if we wanted to know the definition of short bowel syndrome, it is less than 150 centimeter of the gut remain, less than 100 centimeter shows by some books. Then high alimentary tract obstruction like achalasia, stricture, neoplasia, gastric carcinoma, pyloric obstruction. Achalasia, you know, there is loss of ganglion cells in the normal neuromuscular system of the GIT. Strictures are the fibrosis of the lumen. Neoplasia are the tumors, gastric carcinomas, and the pyloric obstructions. So prolonged hypermetabolic period, short bowel syndrome, and high alimentary tract obstruction, these are the indication. Then is the prolonged paralytic ileus. You know what is paralytic ileus? Ileus means stoppage of the gut motility, which occur mostly after major surgical procedure in which there is gut handling, multiple injuries, blunt or open abdominal trauma, and the malabsorption. Fifth one is patient who cannot ingest food, who regurgitate and aspirate secondary to oral or tube feedings, or excessive metabolic requirement secondary to severe trauma such as full thickness burns, major fractures, and soft tissue injuries. And seventh is the enteritis, colitis, malignancies, etc. So up till now we covered the assessment of the nutrition and indication of the nutrition. As I have already discussed with you the routes of nutrition, there are two different routes, enteral nutrition and the parenteral nutrition. Before starting this, some review of the previous slides. So there are two different routes, enteral and parenteral. Enteral route, long-term, for enteral long-term routes, you can use mouth, you can use gastrostomy and jejunostomy tubes, short-term nasogastric tubes. For parenteral nutrition, the peripheral parenteral nutrition, long-term, for TPN, you use the central lines like subclavian and jugular veins. For short-time, peripheral parenteral nutrition, you use the cubital veins, you use the saphenous veins. Approach to nutritional support. First of all, assess the nutritional status of the patient, and then think whether maintenance requirement is required or whether repletion requirement is required. After the assessment of this requirement, go check the GIT tract function. If the GIT tract is functional, then it is better to give the enteral nutrition. If the GIT tract is not functioning, go for the parenteral nutrition. Clear? Okay. This next diagram shows different routes. Look at the one drip is in the subclavian vessel. Second is PPN is in the cubital vein. Then there is a nasogastric tube which is passing through the nose into the stomach. Then there is a gastrostomy tube, jejunostomy tube, nasojejunal tube. So these are different routes of the nutrition. So these are some nutritions which are available in market, little bit costly but can be given to the patient. And if the patient is not affording, you can use a full-fledged good diet at home by using fruits, vegetables, meats, milk, dairy products. So then what are different indications of enteral nutrition and what are different indications of parenteral nutrition? As I already told you, the better route is always enteral nutrition. If the GIT is functional, so better to use the route of enteral nutrition, which is mouth or gastrostomy or jejunostomy. Basically, enteral route is for GIT and other route is for venous system. So indications: poor nutrient retention, prolonged NPO status, insufficient intake. So I hope everything is clear. So first choice is enteral nutrition. Adequate, palatable and varied diet is used. Cleanliness must be preserved at every step. Assistance should be given to patient to take food orally if the patient cannot take, like the patient of stroke, cardiovascular accident. Then tube feeding, unable to take orally but have functional GIT. It maintains intestinal structure and function. It improves immunity. It avoids catheter-related problems. It is more cost-effective. Tubes are passed through nose and named according to location of the terminal end. For example, nasogastric tube, nasoduodenal tube, nasojejunal tube. And most of these tube feeding are for short-term use. Then is the endostomy tube feeding. Endostomy tube feeding can be temporary or permanent, usually performed where feeding is required more than 4 weeks. Passage of nasogastric tube is not possible. These tubes, mostly gastrostomy or enterostomy tubes, mostly passed in the theatre by well-experienced surgeon. But nasogastric or nasojejunal tubes can be easily passed by some house surgeons in the ward by using local applicants. Surgical gastrostomy, the indication of surgical gastrostomy are esophageal atresia, stricture and cancers, dysphagia due to neuromuscular disorder, post-traumatic. Contraindications are primary disease of the stomach, abnormal gastric or duodenal emptying, and significant esophageal reflux. So, you should know what are different types of surgical gastrostomies. These are tubes passed directly inside the stomach by some surgical procedures. Complications of surgical gastrostomies are local irritation, skin exfoliation due to leakage of gastric contents, hemorrhage, intraperitoneal leakage of gastric contents, wound dehiscence. Clear? You can also do the gastrostomy by endoscopic method, which is balloon gastrostomy, which is also called PEG, percutaneous endoscopic gastrostomy. Okay. How will we perform percutaneous endoscopic gastrostomy? Actually, this is mostly done by the gastroenterologist by passing endoscope inside the stomach and wide bore cannula is passed with a balloon at the tip of that cannula inside the stomach, as shown in the diagram. Clear? What are benefits of enteral nutrition over total parenteral nutrition? If the gut works, always prefer enteral nutrition, because enteral nutrition is physiological, nutrients metabolized and utilized more effectively, immunological, gut integrity is maintained by enteral nutrients. Safety. Avoid complications related to intravenous access. When you pass the cannula or catheter, there are chances of catheter sepsis. If you use the main vessels in the neck, there are chances of pneumothorax. You can damage the apex of the lungs, then arterial lacerations, then catheter embolization or thrombosis. Cost effective. Cost of enteral formula is less than parenteral nutrition. Cost of equipment and personnel is also less. Contraindications. Contraindications to enteral nutrition: expected need less than 5 to 10 days, severe acute pancreatitis, high output proximal fistulas, intractable vomiting or diarrhea, peritonitis and ileus. These are the contraindications to enteral nutrition. After giving these parenteral nutrition, it is always necessary to monitor all the scenario. For monitoring, you have to do the serum electrolytes, blood glucose, blood urea nitrogen, serum creatinine, serum calcium, serum phosphorus, magnesium. Electrolytes or blood glucose level should be done on routine basis, on daily basis. Liver enzymes, vital signs, body weight, 24-hour total urea nitrogen level, estimated nutrient intake, all administration routes, fluid intake and output. So all these balance should be monitored. Fluid intake, output, how much feed you have given to the patient, vital signs, body weight, improvement or decrease in body weight, liver enzymes, gut function, electrolytes balance, kidney functions. Parenteral live feeding. TPN is defined as intravenous provision of all nutritional requirements without the use of GIT. Indication of parenteral nutrition: massive intestinal resection, especially if it is less than 100 centimeters small bowel, proximal fistulas, inflammatory bowel disease, ileus, severe pancreatitis. The route of delivery are peripheral parenteral nutrition and the total parenteral nutrition, as it has been already discussed. Complications are catheter sepsis, pneumothorax, arterial laceration, catheter embolization. Cost of enteral nutrition formula is less than total parenteral nutrition formula. So it will end our today's lesson. We have discussed introduction, then we did the assessment by history, by physical examination, by anthropometric measurements, by laboratory test, by immune function, then we go for caloric requirement of the patients, other nutrition requirements. We discuss indications of nutritional sports, then we discuss the routes of nutrition, how we'll approach the patient who needs nutritional support, what are different types of nutrition, what are different paths or ways of nutrition. So we covered all the things regarding the nutrition. I hope you all be cleared of all these things, but if there is any question, you can ask the question. You can ask me question today or tomorrow. Attendance will be taken during the lecture or after the lecture. No attendance will be countable. So it is advisable to please be there at 8 to 8:45 p.m. After 9 p.m. there will be no attendance. After 9 a.m. there will be no attendance. So question regarding this can be asked at any time. Thank you very much.